interesting panel discussion, how to manage a difficult case from soup to nuts. The moderator, Dr. Anil D. Cruz. He has more than experience of 30 years, currently Director of Oncology at Apollo Hospitals, former Director of Memorial Hospital, and he was the first President of Union of International Cancer Control, and he will be heading the moderation for this panel. So inviting on the stage the panelists, Dr. Anuj Shah. He is a consultant head and neck surgical oncologist at HCG Asta Cancer Center, Ahmedabad. Professor Dr. Ashok Shanoy, Professor and Head Department of Head and Neck Surgery, Ujjain Cancer Center. Dr. Neerav Trivedi, he is a consultant head and neck cancer surgeon at Shanku's Mid-City Hospital, Mehsana. Dr. Prakash Odedra, he is a consultant radiologist at HCG Asta Cancer Center, Ahmedabad. Dr. Ravi Dev, who is currently the head and neck oncologist at Asta Cancer International Institute of Oncology, Bangalore. Dr. Rohit Nair, who is a senior consultant director and clinical administrator at Max Super Speciality Hospital, New Delhi. Dr. Samaratnam Main Vagnan, who is an additional professor. And Dr. Subhalakshmi Sen Gupta, he is a senior consultant at Medical Cancer Hospital in Kolkata. Do we have all the panelists on the dais?
Screen up.
Yes, okay.
दोनों साइड आ रहा है
ये 5 okay, lovely. So good evening guys, we've got 42 minutes left. Great. So how to manage a difficult case from soup to nuts? Dr. Chaukar told me the first question I should put up to the panelists is what you all understood from this topic, soup to nuts. Did anybody make sense of it? I asked everybody. Kostub said I didn't give the name. Aditya said I didn't give the name. Deepak Sarin gave the name. So I went to Deepak Sarin because he's trained in Florida. I thought it's something great from there. It is a US slang. It means from beginning to end. So we're going to do something that you all must know everything in thyroid. There are some other names for soup to nuts. You sometimes call it from pottage to cheese. That's across the entire meal. So they started with soup, they ended with cheese and nuts in the old days, before we had pastries and things like that. And it's also called from soda to hawk. That's a card game that they played in the time of pharaohs. So it means from A to Z on thyroid. The first case given by Rohit Nair, and I put the slides up verbatim, I've not modified it. 43-year-old female, no comorbidities, neck swelling, hoarseness of voice, dysphonia, papillary thyroid cancer with lung mets. Here are the findings. He's done a PET scan, bilateral thyroid nodules, bilateral lymph nodes, subpleural metastasis in the lung, left cord had restricted mobility. He's evaluated the esophagus and there's no evidence of esophageal compression. He's done surgery on the 16th of July and the patient has a subtotal thyroidectomy, bilateral central compartment clearance, bilateral selective neck dissection, July 25. Intraoperatively, it was an aggressive disease. The left nerve was sacrificed. He's done an anastomosis and the right recurrent laryngeal nerve has been preserved with a cuff of tissue. Comments from the panelists. Good, bad, could we have done anything differently? Anything, or is everything going beautiful for you all? Anybody, any order. You want me to take names? I can take names, but feel free to answer. And let's go fast. We already 39 minutes and we started late. Let's go.
Sir, actually, aggressive disease and it's a metastatic disease as well. Right? And
Okay.
so total thyroidectomy with bilateral central compartment with bilateral selective clearance should be done.
I'll be more focused. So he is operated, he's done a subtotal thyroidectomy. I presume the subtotal is done because he couldn't take out all the disease. Otherwise, we don't do subtotal. Now, I presented in my talk, and Abhishek Vaidya also spoke about neoadjuvant chemotherapy in this patient. Comments from left to right, anybody uses neoadjuvant? Would you now change your approach? Maybe Rohit can answer. Now that you went and saw this brutal disease, you've left back disease on one cord, you've sacrificed one cord.
Yes, there are now data available, and there are retrospective data for neoadjuvant therapies, particularly TKIs, in well-differentiated thyroid cancers. So that's also one of the options. And the other is to give him the radioiodine treatment. So
We don't have a nuclear physician on the panel. Anybody would believe radioiodine would sterilize clumps of disease?
It's not a good scenario for radioiodine disease. In the light of current data, which you have, a lot of data has come from Randolph's group, which you alluded to, and a lot of data has come from Europe also, saying that perhaps the age is very young, and you know that one cord is already sluggish, so your CT scan must be showing you that kind of a picture, if you have the CT scan pictures, but I assume that your group would have been effaced. So if that evidence is there, maybe it's a better thing to go in for a neoadjuvant chemotherapy since he is young, and then go in for, if possible, if it improves.
So in hindsight, we are always wiser, and maybe we should. Radiologist is who? Prakash, is it? Prakash.
Sir,
Okay, Prakash, can you give the surgeons a clue that they're going to leave back R2 disease when you view a CT scan? Anything that we should look for, that the trachea is involved? Any clues for locally advanced cancer?
so if it's a contrast enhanced CT scan, the clues to aggressive disease is extra thyroid spread outside, which is in the tracheoesophageal groove, going towards the location of recurrent laryngeal node. Indirect signs like palsy causing dilatation of pyriform fossa, deviation of arytenoid cartilage, or direct invasion of structures like trachea itself with endometrial tumor seen on CT scan, or infiltration of esophagus itself.
So, quick things in my book to pick up this extrathyroidal spread. Whenever you'll do a sonography on the thyroid, your doctor, your sonologist must tell you whether it's touching the posterior capsule. If there is no rim of thyroid tissue between your nodule and the posterior capsule, even if the cords are mobile, you must have a CT scan. Second, if the entire nodule has replaced the lobe and it's more than 4 centimeters, please always have a CT scan. These are mandatory. In this case, I would definitely have given neoadjuvant because the opposite TO groove is full of disease and the patient has a restricted cord mobility on one side. So I think the learning for me in this case is probably I would have gone back and given neoadjuvant chemotherapy, waited for some time, and the results are pretty promising. Progression is not described. And I will put some other cases as well for locally advanced. Next, here is his pathologist. Diffusing sclerosing variant of PAPCA, 4.3 centimeters, T3A, N1B. Pathologist, madam, comments, aggressive variants. Any comments on diffuse sclerosis? Then we'll ask the clinical people what they would do.
So this is an aggressive variant of papillary carcinoma where we get like lots of fibrosis, lots of samama bodies, and lymphoid infiltrate, and these are associated with extrathyroid extension, propensity for lymph node mets, more propensity for lymph node mets and distal mets as well. And there is extensive lymphovascular invasion. WHO states that we should separate angio invasion and lymphatic invasion now and not club together as lymphovascular invasion. And extrathyroid extension, according to WHO, only if this is grossly examined and that it should go into the strap muscles. And microscopic ETE is not taken into account right now.
So this is a diffuse sclerosing type and it's known to be aggressive. Diffuse sclerosing occurs in young people and there's intense fibrosis of the entire tissue. It's one of the aggressive forms. Just for the records, the WHO 2022 has 13 variants of papillary thyroid cancer. The majority of them are aggressive, all the variants. So great. Rohit went and did this on his patients, PDL1 and a BRAF, which was negative, and he wants to know what should be the course of action. Philosophy. Will we give radioiodine? Will you give radioiodine followed by EBRT? What would you do? Broad philosophy. Guys, wake up.
Sir, actually, if it is taking up, the scan is taking up radioiodine, then ablation can be done. And instead of EBRT, I would prefer to give in this patient tyrosine kinase inhibitors post-surgery because it's a poor resection as well. There have been trials which have shown benefits.
So let's take this in two parts. External beam radiotherapy. So we'll definitely give radioiodine. Every panelist agrees. Should we give external beam radiotherapy? Yes, no.
The external beam radiotherapy is less efficacious in this setting.
That is well established. But should we give it now? Should we wait? What is your philosophy when you give external beam radiotherapy? Anybody, you all can hop up. Gauri, come sit here. In your time, everybody was speaking. Come here, bring your chair here, please. Gauri is here, so you all can answer.
What estimation of thyroid globulin give us an index how effective the radioiodine treatment would be? Then we can decide about external beam therapy. Because if thyroglobulin is not raised at all, and we have gross disease, then probably with the tyrosine inhibitor along with external beam therapy should be the first kind of treatment.
Is Dr. Bal around? Any other new Manas? No one, they've gone. Archie is there. Archie, come on. Do you decide on thyroglobulin deciding on your...
At present, the guidelines don't mention about TG. It is only the pathology that we see and the perioperative notes, and based on that, you will stratify the patient and then give radioactive iodine. At present, there is no stratification based on thyroglobulin. So you could have aggressive variant or you could have vascular invasion where post-surgery your TG is very low, but based on the histopathology, you will go ahead and give radioactive iodine because it is an intermediate risk or a high intermediate risk patient.
But she has lung mets as well. She has lung metastasis as well. She has lung metastasis.
I just came in, so if she has metastasis, then
No, she has to give. We are just asking.
Yeah.
But again, my philosophy, and you can correct me if I'm wrong, I do use thyroglobulin when I don't want to give radioiodine. So I've done a total thyroid. I monitor thyroglobulin. If I see an elevation, I'll go back and give radioiodine. That's very well described, and that's my approach now for 2/3 of intermediate grade thyroid cancer. So that's the only time. So quickly, radiotherapy should never be given in differentiated thyroid cancer unless you have ruled out that you will never go back into that neck again. So please remember this. Don't run and give radiotherapy. You will screw up every chance of someone going and doing a tracheal resection, doing whatever you want to. So please don't give radiotherapy. It could be external beam, RAI, monitor the patient. Someday I may consider external beam. Quick question. He said that he would give, just 1 minute. He said he would give TK, wait there. TKIs. Anybody TKIs straight after radioiodine? TKIs? No. So the philosophy of TKIs are costly. they have side effects. You never give TKIs unless you have structural progression of disease or you want to preempt a complication. Otherwise, TKIs are not to be given in asymptomatic patients. So I won't give it. I'll give it some years later when you have structural progression of disease. So Rohit, does this answer your case? Everything? Any other questions? You can go back to that girl and tell her that the whole house gave these opinions.
So that's what the RAI and the thyroglobulin levels, and then you call them again after 6 months and then again do a scan and see how
Absolutely.
they have responded. So how
Absolutely.
RAI has affected the
Absolutely.
progression of the
KK.
So, I just want to make a point that some of these aggressive variants, like diffuse sclerosing, they may not take up radioiodine.
Correct.
And then what we do is we give a empirical dose of high dose radioiodine followed by EBRT, or sometimes in poorly differentiated types, the EBRT comes first and later, like an empirical.
No. There I'm a little at disagreement. Archie, come up.
So in a radioiodine refractory, basically if it's 10 years over radioiodine refractory setting,
He is not saying refractory.
that's what he said, no radioactive iodine concentration, right?
No. He said sometimes I give external beam first and then I give radioiodine.
No, so
No,
then
that's not
radioactive
to be
iodine.
done ever.
Yeah,
Okay.
Yeah.
Okay, but it's never RT first. I understood as RT first, but no. You said sometimes I give RT first. No. Anyway, let's not what he said. I just want to say that you don't give external beam first. Okay, Akshat.
So like in this particular case, it was a diffuse sclerosing variant. I was there in the case. Now it's very difficult to cut through a diffuse sclerosing variant. You cannot shade the disease of the body. You end up leaving quite a chunk of tissue out there. So it's an RT disease. We have had recent publication with PMH also where they have showed role of RT in RT resection. So like Gordon Adam is also there, so I wanted to know about that something because this would be a case for that.
So if the patient is taking up radioiodine, you will give radioiodine and not RT. When you're not going to operate and it's not taking up radioiodine, you will give this. It's a different, if you have clumps of disease, bilateral nodes, extracapsular spread, that's a different thing. But you read any literature, by and large, RT is not to be given. So please interpret the data correctly. Don't give RT.
Okay.
There are four others waiting in line. Can Madam speak before you all? Of course, Madam is present. Madam. Correct. We'll see progression.
Sir, only one question I wanted to ask. We have
You
already,
can't ask me questions, you have to ask them questions.
yeah, so we
Look
have
at them.
already transected one nerve. We have left R2 disease on the contralateral nerve, which is now with impaired mobility. We are dealing with the aggressive variant, which may or may not be RAI avid. We're not going to go back in to take out the residual disease. So does it make a point to give EBRT after RAI in this scenario?
No, you're in again. Anybody, Harsh is agreeing with you. Anybody else? Panelists?
I think you can try RAI once, twice, because it is likely that this will go into the poorly differentiated variant sooner, or it will not absorb enough of radioiodine to be efficacious. So at that point in time, you take a call for EBRT. Until that time, I think you can wait to repeat the RAI. I wish Madam Agarwal can give us
Let Shiva.
So, sir, going by the history, a 23-year-old female patient who had lung mets and multiple neck nodes. So, looking at it, I somehow feel this could have been a pediatric thyroid malignancy which was manifested much later in life. And it's a diffuse sclerosing malignancy as well, which is more common in radiation-induced thyroid malignancy. So, would that be pertinent to go back and take a thorough history and just check if there was any radiation exposure or something? And anyways, pediatric malignancies They do much better than if it was an adult patient. So I'm just thinking, would that make a difference?
That's theoretical. You can take 200 histories. It won't change the management.
No, meaning to say, could this be considered as a pediatric malignancy which is
But
manufactured?
how does it change?
Outcomes are different. Outcomes are different for the treatment would be the same. The outcomes may be better compared to adults.
You leave residual disease.
43, is it? No, because it was, I thought it was 23, or maybe I'm mistaken. Okay.
43. Right.
Subbu.
No, the question about the recurrent nerve and this thing. See, I fully endorse your point that you shouldn't jump into radiation. Most of the cases, you give it for recurrent bonding, the nerve will be screwed up with the radiation. Or if you want to do a laryngectomy, then it's, you're taking off all the issues for the patient from surgery in that way. So that's why I would fully endorse what Anil was saying.
My good day, Subbu.
No, I just want to say one thing on our experience on the phase 2 randomized trial where we are doing EBRT versus no EBRT in locally advanced thyroid cancers. With using IMRT, we have gone back and operated some of these. It's not really that bad. So I would like to say it's a prospective randomized study. We've looked at these patients, we've gone back. If you use good IMRT, it's not really something that you cannot go back and operate. And I agree with Richa that you're probably never going to go back unless the opposite cord suddenly starts functioning. If the opposite cord is going to be fixed and this cord is going to be restricted, I think we should use radioactive iodine followed by EBRT in this patient, though I agree with what you and Dr. Iyer said, that in most cases, do not use external.
Okay, I'll tell you, there's no right or wrong answer, but I don't agree with her and Richa, and I'll tell you all why. You'll make your value judgment. Once you give RT, it's not going to act on that clump. It's going to delay progression. The patient is going to have problems. This is a classical case to give EBRT. It's 20 times more potent than external RT. There's a high uptake, hold RT in reserve. Because the cord is immobile or restricted mobility, we want to preempt a complication of a fixed cord. That's when the TKIs jump in. And that's one of the indications. So I'll buy time. You don't give someone RT. This patient is going to live for 15 years. Will have side effects of RT. You may want to go in later. So I would by all means give the patient RAI and give the patient's TKI, but it's open. You can do what you want in these kind of cases. There's no right or wrong. And a phase 2 is just looking at loco-regional control. It's not telling you what to do in this case. And we all operate post-RT, twice RT given for oral cancer, and we operate. So it's not, but in those operations, it's different from saving delicate structures like nerves and parathyroids. It's a totally different kettle of fish saying, I operate after RT. It's a different, like I said, we operate sometime twice. So case done. Next case, 71-year-old lady comes from overseas, pain radiating to the left shoulder 6 to 8 weeks. Here she is, here is a lesion, there's the clavicle. You can see that little swelling there on the clavicle. If it's not seen, believe me, it's there. This is the ultrasound findings. No suspicious lymphadenopathy. Panelists, Nirav, what will you do? Don't say surgery. We'll have to do some investigations first.
So first would be a sonography, and then a sonography.
Sonography is up there.
Yeah, and then a guided FNSC.
From where?
So there is a microcalcification in the right lobe of thyroid. So that's what I would target. At the same time, the clavicle as well, if it's possible, then would do from there as well.
Also, quickly to tell you that we put the needle in, it was a Bethesda 4.
Before that, I would do a CT scan because there is a pain radiating to the arm, and it is maybe possible that
CT scan, PET CT scan.
because we want to know if the brachial plexus is being involved and things like that. So we need to assess that to know what is the extent
She
of
has
that.
got a clavicular swelling, which is obviously metastatic or probably
No,
metastatic.
I am talking about the primary pressing onto the brachial plexus invasion.
So we'll do further imaging. Harsh.
Age is 71. She has a clavicular met. I would try and do a bone biopsy or a true gut biopsy. After imaging, but I would add that to the FNAC.
Okay, so here's what happened. So we did the FNAC from the thyroid, it came as a Bethesda 4. Here is the PET scan. We did PET because it's metastatic. It could be a kidney lesion going up. It need not be thyroid. We are sitting in a thyroid panel. So we say we want to do brachial plexus. This could be a met in the cervical spine. It could be a met in the clavicle. And it could be kidney with an incidental thyroid swelling. And that's why a Bethesda 4. So in my book, you do a PET scan, and that's exactly what we did. And here is the findings. FDG avid lesions involving both lobes of the thyroid, non-FDG subcentimetric lung mets, hypermetabolic lytic lesion, multiple axial and appendicular skeleton, soft tissue component at C2, C3, and vertebral lesions showing intraspinal extension. So we've got a Bethesda 4. We've got this PET scan. Now what would we do? Should we take Harsh's and do a biopsy? Correct?
Yeah, get it through.
Great. Where will you biopsy it from? Patient has multiple bone mets.
One to even so thyroid, if we can get the mass is also true cut.
Bethesda 4.
No, true cut biopsy. So FNS is Bethesda
So
4.
again, we won't do a true cut because majority of bone metastasis, though they come in papillary, are follicular, and a true cut will not help you. So when you have metastatic disease, you don't biopsy the thyroid. That just to answer the question about thyroglobulin, we sometimes use thyroglobulin as a surrogate to tell you whether you have bone mets. Upwards of 100 probability of bone mets, because in those cases, we cannot biopsy. It may be in the brain, it may be at C1, C2, impending, difficult to hit the biopsy. Then we'll use thyroglobulin as a surrogate. Otherwise, we'll biopsy the most accessible bone met, absolutely, which is on the surface and will cause less problems. So we did that, and they said consistent with follicular. Shiva.
So I just was wondering, is a biopsy absolutely essential? Because since it is having bone mets and FNAC is Bethesda 4, if I do a thyroglobulin, if it is elevated, it's most likely to be mets from follicular carcinoma than anything else, until and unless I suspect it's an anaplastic. Just to rule out an anaplastic, I might do a biopsy. But otherwise, if the thyroglobulin is elevated, even anaplastic is most likely ruled out. So wouldn't that be sufficient?
So anybody wants to answer, Shiva? Or I'll answer.
Clavicular involvement is so easily accessible. In addition to whatever you got already, I don't think there is any harm to do that, and we'll substantiate our diagnosis. That's all.
So it's just going to be less invasive and the results are going to be evident.
I won't dispute with you.
No. So you are not wrong, but you are not entirely correct. The reason is, in an occasional case, you will take up thyroglobulin doesn't govern surgery. Thyroglobulin governs post-operative follow-up. It doesn't govern surgery. We also do it in a hemithyroid. I do it in hemithyroid. It shows me the trend. So if it was not accessible or the biopsy is up, this is on the surface. Your guys on ground floor just put a needle in, you're 200% sure. It is no morbidity. I mean, you can do it in your OPD there in 202 room.
So he has metastatic disease.
Yeah.
So we should do a tissue structure so as to plan
surgery. Absolutely.
Not surgery, so systemic therapy if ever needed as well.
No, so you want operator? It comes as follicular in the.
Of course, if it's follicular, then definitely yes. But chances of her having a adverse histology.
Next step. What do we do next? So here's the PET. We've got the follicular on the biopsy. What do we do?
No, I would go ahead with the serum thyroglobulin to see the systemic spread. Okay. And this is systemic disease. So in this sort of situation, you know that, and it's probably unresectable to get an R0 resection, or maybe.
Why do you say that? It's a thyroid there. I can see it sitting. It's up in the neck. I mean, it's not Rohit's case, this is another case.
Okay.
You will operate, everybody will operate, all are operating.
No, I would,
So would we just go into the operating rooms or you'll want to do something else?
no, look at the mediastinal nodes down in the axial cuts in the upper mediastinum. Do you think you can get a clearance on that?
Yeah, look at the sagittal picture.
No, I'm not looking at the sagittal, I'm looking at the axial.
Yeah, that's just one cut, Ashok.
Yeah.
Trust me, you can't even see the
And there's
vena
brachial
cava.
compression there, it would be a 71-year-old
No, but
lady.
trust me, it came out beautifully.
Okay.
I mean, on one scan, I won't say it, it looks worrisome. You look at operability, if you can get an RCO.
Is she having any neurological problem since the cervical vertebra you said is eroded?
So she had excellent
Extension.
point. She has pain, she has no weakness. She's a nice African lady. She sits, smiles at me every time I walk into the room. She's good.
So another thing is to do a BRAF V600 assessment on the biopsy material as well. So
Why?
if she is strongly positive for that, then we can start with the neoadjuvant treatment for her.
No, I'm not agreeing. Why do you want to do that? I'm just finding everybody is getting muddled with these molecular markers. Maybe you didn't listen to me in the morning when I spoke.
See, if you see the nodal mats on this axial scan, because maybe these are the two different patients, one showing the other and the other one showing that.
It's the same.
Because both are showing very different, varied pictures both ways.
Oh, no.
Yeah, this is a non-contrast. So your PET CT are without contrast?
No, now this is some of the pictures. We always do it with contrast.
Yeah, so because then the crux of the matter is if this is operable thyroid follicular carcinoma, we must operate.
Let's not waste time. This is operable. I'm telling you all, let's not fight about it's going near the axil, that's going here and there. So now tell me, we have this PET scan. Would you evaluate further or would you go into the operating rooms? I'm saying no for BRAF.
No, so what I do is,
You can do the thyroglobulin, you can do the calcitonin if you want, and you can do a CA.
so I'll do an MRI neck for her to see the intraspinal extension of cervical spine.
That's a great point. You must evaluate spinal metastasis. Remember, this is what soup to nuts, nuts to soup to nuts. So you must evaluate any skeletal metastasis for bone integrity. And this is what you must know. So you must do an MRI, because if you extend someone with a C2, C3 spinal met and you cause cord compression, the patient will be like Christopher Reeves. Okay,
Sir,
great.
could I
Here
just
it
make
is.
one point there? In the PET scan, it's written that it is compressing on the spinal cord. Before I attend to the thyroid, I will send this patient for EBRT, because after the thyroid removal, when patient goes for withdrawal, she may develop paraparesis, or depending upon wherever the lesion is. So I'll give EBRT to the spine.
Upfront.
Upfront before thyroid surgery.
I differ on
Everybody
that.
agrees?
I differ on that.
I differ too.
Looking at the next picture of your MRI, which you had shown in the next slide, I will like to involve the spinal surgeon with me. While doing total thyroidectomy, we will fix the cervical spine as well, because it's an anterior approach. You have to put a cage in to fix the cervical
So
spine.
again, great points. I would take a neurosurgical consult. I will look which part of the vertebra is involved, anterior, posterior. I would look at integrity of the bone and then take a call whether I want to fix that spine before I give external beam RT. If the bone is destroyed, I mean, Sarvani can radiate 10,000 rads, that bone integrity will never come back. When you extend, she'll get paraplegia. So you must take spinal integrity. If the spine is going to be tricky, you will fix the bone first after selective embolization in a follicular CA, and then go ahead with thyroid. Okay, go ahead.
Yeah, no, the same.
Today, my good day, Subbu agreed, you agreed. I agree. Acha, okay, nice. Harsh, Mitali.
So just one point, after fixation of the spine, one must remember that this is going to be a very difficult thyroid to perform.
No, it wasn't difficult.
Because neck extension would by and large
That's
be,
a good point.
it's a
That neck extension-
thyroidectomy inflection.
But
So
when
that is
I
something one must.
trust my clinical judgment, you have worked with me, it didn't look a difficult thyroid to do. Go ahead.
So I'm sticking my neck out a bit and being a little cheeky, but you always taught us that when you're planning to fix the spine in top, these lesions are very vascular. So to always send them for radiation first.
No,
so
no,
to reduce the
selective
vascularity.
embolization. Science has moved. Science has moved, my friend. Okay, so I went through that phase when I spoke to you, then I got gray hair like you, now it's all fallen off. So science has moved. So we'll do selective embolization and we'll take this patient for surgery. So here's what happened. Just to answer y'all, we did biopsy. It was metastatic follicular. TG was more than 300. This is the surgery that we did. I called the spinal surgeon in. I exposed the spine anteriorly. It was high up at C2. He couldn't reach it. I took a decision to go ahead with the thyroidectomy, taking consent. Son was a doctor. I told him, if you decompress post-operatively, we will rush you back into the operating rooms and decompress the spine. I could get it out. I got it out clean, and that's the surgery that I did. Comments from, okay, we'll come to Archie. I think Archie, you gave RAI on this patient, but hang on, we'll come to you. Okay, great. Here's the histology. Okay, so it came as poorly differentiated. Largest was this, capsular invasion, angio, KI 67, 7 to 8%, and the nodes were all negative. Further treatment, guys. RT, RAI, TKIs, external beam RT. Okay, everybody is quiet. Come on, guys.
But thyroglobulin was very high in this patient, and therefore there is a case to give radioactive iodine.
250%. There's no doubt about it. So in every thyroid cancer that you operate, it may not take up, but you will give external beam RT. I mean RAI. We will give RAI. So we gave RAI and Archie, or maybe the panelists, and then we'll ask Archie.
Would you like to do some molecular test on this? It's a poorly differentiated tumor.
नहीं मॉलिक्यूलर के पीछे क्यों पड़े हो यार मॉलिक्यूलर मॉलिक्यूलर
मेटास्टेटिक डिजीज है
नहीं तो क्या करोगे चलो मैंने KRAS कर दिया I did TERT and I did BRAF. BRAF is positive, TERT negative. So now NTRK also it's negative. I know you have mutation negative.
So what next are you going to do for this?
अभी मैं पूछ रहा हूँ ना questions I ask you have to answer.
BRAF positive है इसका and now she has multiple bone mets.
Folks, at least do one thing when you leave Gujarat. Know that molecule has a very limited role. Only if you want to give focused, targeted therapy, you do molecule. And if you want to type certain tumors in path, and you must read WHO classification 2022. Some of the benign hyalinizing trabecular type, they do something called GLIS1, GLIS3. There are various things only to get those. Otherwise, there's no role for this targeted. And the second thing, when you leave Gujarat, know that it's a dry state. That's all you have to know in this.
So go. So regarding molecular testing, sir, but see if they are red fusion.
So
At least it should be taken quickly. That's what I'm saying.
We'll do it. We don't have to do it now. That spinal net is growing. The TSH is going up. Now, how will you give radio ID? She's got a spinal net that is precarious. How will you give radio iodine in a precarious metastasis?
Recombinant TSH.
So the first thing is an absolute no. Recombinant TSH does not have FDA approval for metastatic disease. In this country, a lot of people give it. Archie, correct me if I'm wrong. You get what's known as a flare. When the TSH goes up, there'll be a flare. And the flare will push on that spinal cord. And you'll go to court and use your license. So no recombinant TSH. Would you agree with me, Archie?
Yes.
Great. So how will we give how will we give the radio ID?
Sir, we can start on T3. Meanwhile, we can stop it 15 days before.
So we'll watch for the TSH to go up, do not wait for the TSH to become 124. Once it's above 30, you can go for radioiodine. But the most important thing in spinal meds, which are precarious, and brain meds, you always give radioiodine under steroid cover. So the patient must get high doses of steroids starting now. Wait for the TSH to come up. We monitored it weekly. The moment she had a high TSH, we sent her to 40 on the 15th of September. Archie, come take over. You can read, those are your reports up there.
Okay, so after surgery, I mean, we just managed her on Linorma, as you said. We gave her Linorma for a few days, so for 15 days or so, and then as the TSH was rising, but sometimes it can happen that if you have functional metastasis, your TSH doesn't rise, but in this patient, the TSH rose above 30, and as soon as it was high, we treated her with 200 millicuries. So now normally, I mean, with the older ATA 2015, you would have treated with 250, but by this time the newer classification had come and it says distant metastasis, you should be treating with 200 is the upper limit. So we treated with 250, and before giving radioactive iodine, 3 days prior, we started her on steroids, 8 milligrams BT, and for the steroids to take action, and so that you don't have that inflammation that occurs in the C2, C3. We were very cautious about that C2, C3 should not cause any inflammation, and then she goes into, after giving RAI, she goes into paraparesis or something like that. But luckily, she did not have any side effects when she was within the ward, and we could effectively manage her with steroids and radioactive iodine. And subsequently, I mean, we did a post-therapy scan. There was some amount of uptake in the C2, C3. I don't know, someone else must have reported, but there was a very low-grade uptake that was seen in C2, C3 when we did the SPECT.
Now what will we do? Shilpi. No, Shilpi.
But I'm slightly confused over here. We do know that we don't have FDA approval for recombinant TSH in metastatic setting, but there is something known as compassionate ground. And they have mentioned, and there are various studies where in metastatic setting, especially we used to, normally we say that when you have brain metastasis, when you have spinal metastasis, when there is impending spinal cord compression, you don't want your TSH to be prolonged over the, weeks, and we just give recombinant in 48 hours, you just start therapy. So, is it really going to be that much of difference if you just give 2 days of therapy and then if we just start RAI?
Tell me who has given on compassionate grounds recombinant?
So it's in the US, it's not in India.
In but US, they're very particular. They will not give.
No, sir, there is a publication. They have mentioned that
publications. There may be publications. You want to give it, you give it. But I am telling you, there's something known as a flare, well described. I told you there are no right or wrong answers. I showed you the guidelines in the morning. There are at least 50 flaws in those guidelines. Apply to community. It's not about you reading one publication and coming here. I'd love to read it, and maybe the next ISTS we can have a discussion on recombinant in that. Azhar.
So correct me if I'm wrong, probably Matt was not operated upon, so Matt was left there.
Yeah, was left.
Metastasis left there and the TB got compressed.
Yeah.
So it doesn't make sense to give a RT because if you are given radioactive iodine here, it's going to take months to act. And we have got a cord which is almost been compressed. RT will have faster results.
Again,
so that is the again, you should
any radiation, how much of dose will you give? And please don't think I'm abrasive. When you give RT to bone metastasis, who is here? There are 2-3 protocols that you'll give. 400 into 5. It doesn't cure cancer.
So, but issue here is cord is already compressed.
It prevents progression of bone metastasis. Any radiation oncologist in the audience? Please remember, RT is not given. You have to fix the spine. If it is not structural integrity gone, then you can give external beam RT when it doesn't take up. So now we come to the question of what next for this patient. So to make Akshat and Rohit happy, I now sent an NGS for molecular markers to see whether there were specific actionable mutations. I have told them to go and get the spine fixed, and then I'll take a decision on whether you want to give external beam RT or not. I didn't, but now, no, he'll use a posterior approach. From the anterior approach, it wasn't. I would have to turn the patient upside down. So whenever you fix spinal, you either do an anterior or a posterior approach. So he'll put a posterior approach and he'll put 2 rods and he'll fix the spine.
So can I make a comment on Shilpi's question? So she's right when she's saying that there's a publication on given.
I'm not denying it.
Yeah,
I'm not denying
but
it.
you know, sir, I agree with you that, you know, there's a lot of flare and the patient, because the PSH rises suddenly and, you know, it can cause
It is unpredictable.
Yes, sir. And moreover, even if when I have tried in 2 patients who had skeletal metastasis and I got they said you should be treating with thyrogen. These patients I have tried, they are miserable after giving thyrogen. They do not take up thyrogen. I mean, they do not tolerate that thyrogen very well, and it is not actually indicated when only for less than 100 millicuries you can give thyrogen, otherwise no, not with skeletal metastasis.
So I totally
You can
agree.
very well manage them with Linorma and steroids, and if needed, if the patient goes into some sort of compression, then RT at that point.
So I'm ending, the time's over. I had 5 beautiful cases, but I think one gave us enough soup and nuts. But I want you all to leave with this one message. Don't read one publication and come. I told you, meta-analysis data, people jump up and say, sir, there's one publication. Read it properly and apply it to the biology. I'm not denying, if you have a better treatment and you can give steroid cover, it is safer. You can go ahead and give it. I mean, I'm not fighting with you about you giving it, but you have a flare and you have a paraplegia, you can't bring that publication up to the court and tell them that I've got a publication, that's why I gave it. Do value judgment. If you think it's better, please do it for your patient. I don't know right or wrong answer. I've shared my philosophy with you all on how to treat a difficult, and Kostu wanted something which is what you call jhol ye bolte hain na, yahan pe jhol type of case, and that's what I did. Comments from the panelists. Many of you all have not spoken. Please make one quick comment and
How about going the reverse way? Because you fix the spine first, posterior approach, and then do your thyroid.
You can.
Yeah,
you can.
that would have been a more safer than the flexion of the spine, which everybody was talking
Ashok,
about.
I totally agree with you. That is a possible approach.
that's the
but
only
I
thing.
took a value judgment based on no neurological defect. She had no pain when she was in the hospital, and she was wearing a brace and moving all around happily. So I took a judgment, and plus she was international, so I had a limited time and she had a limited budget as well. But I took a value judgment. I didn't take a risk of giving her that. Comments? Any comments? Anybody from the floor wants to make a comment?
Sir, actually, the role of anti-resorptive therapy is also there.
Yeah, sure.
And that has to be done first because it's soup to nuts. And then, Madam said, bone meds take up radioiodine, but the sodium iodide symporter expression in bone meds is not so great as like lymph nodes, central compartment lymph nodes or lateral nodes. So that's again, there are a lot of literature saying whether will be there, because she said only a faint uptake was there. So that's a point there.
No, just come again. I'm not sure I totally agree with this again. Lymph nodes may have lesser sodium iodide symporter than on the bone. So it's not, lymph nodes is a surgical disease. Please don't burn lymph nodes with radioiodine. 10 to 15% of lymph nodes who have occult metastasis will get burnt. 85% will stay there and you'll have given 200 millicuries unnecessary. Nodes are a surgical disease. Harsh.
So if you could just leave us with a few lines on when would you order a molecular diagnostic?
Molecular.
So because there's so much in the air right now. There's so much of molecular going on, but we would definitely want. What would be your specific indications when you
want me to answer or these guys to answer? So tell me, I'll tell you, where are the 4 places you use molecular?
In the neoadjuvant setting?
No, you use it for diagnosis. 2, prognostication. 3,
treatment.
WHO classification of pathology. And 4, treatment. Now you tell me when to do it.
Yes.
This is standard.
Any role of,
ये तो पहले ही पूछा.
just to add, any role of biphosphonates in the bone?
Yeah.